Today's learning objectives in the presentation are what are the components of our immune system and how our immune system is equipped to detect and eliminate cancers. And secondly, how to describe how tumors can evade these immune recognition and destruction. And then identify ways to target immune mechanisms for cancer treatment, and describe the role of immune checkpoint pathways in cancer. Next slide. So, Pradyumna, who will move? Can I move the slides? No. Okay, you're moving. Keep moving. No. Next slide.
Okay. Okay.
Yeah. So this is a very impressive curve. What you can see is the immune system is important in cancer development. So if a person is more immunosuppressed, he becomes more susceptible to cancer. So we have heard that immune system is important to defend against cancers, but defend against infections. So we have heard of COVID that if the immunity is low, then we become more susceptible for infections. Similarly, immunity is required even for prevention from cancer. So if you look into immunosuppressive conditions like HIV and AIDS, or you look into immune suppression because of post-organ transplant immune suppression. So if you have immune suppression due to any reasons, whether it is HIV or AIDS, whether it is post-transplant immune suppression, on all these occasions, the incidence of cancer is higher than the garden subgroup. So definitely the immune surveillance. So normally in a human being there is always a tendency for mutations and a tendency for oncogenesis, but there is always a constant immune surveillance to take care of it, so that the cancers don't happen much frequently. So we have cells equipped in our body to find out the self antigens, the non-self antigens. So all these equipped mechanisms which are there in place to prevent development of cancer. So whenever there is immune suppression due to any reason, whether it is post-transplant immunosuppression or HIV-induced immunosuppression, or even subtle immunosuppressions, like we can add stress, sleeplessness, so all these subtle reasons, diet, so they all have some immune alteration, and maybe these are the reasons why some people become more susceptible for cancer. So immunity and cancer are very closely related, just like immunity and infections. So if you have a prolonged immunosuppression, you are at a higher risk of developing cancer. So for cancer, the most important risk factor is age. So the more elder we become, our cells become more mutagenic and cancer develops. So this is a non-modifiable risk factor. We cannot stop our age. And whereas immunity, to have an intact immunity is somewhat modifiable. So having an intact immune system with a proper immune surveillance is an extremely important mechanism to prevent oncogenesis. Next slide. So it is a similar slide that has been repeated in a couple of two slides. So you keep skipping, Pradyumna. Yeah. So then if you look into which are the immune cells which are quite important in immune surveillance, we have natural killer cells, we have macrophages, we have T cells, we have B cells, we have dendritic cells. So in immunity we have what is known as an innate immunity, where it is not specific to the type of antigen that is attacking, whereas adaptive immunity is a specific immunity where it targets specific cells and causes target cell killing. So if you look into macrophages or dendritic cells, so these are part of innate immunity, and they are not specific for or natural killer cells, so they are not specific for the antigen. Whereas if you look into adaptive immunity like T cells and B cells, so they have their own final modifications adapted to the specific antigen. Whereas the innate cells are the same for all sorts of antigens. They don't have adaptivity. They don't have their specific changes with them for that specific antigen. Whereas the adaptive immunity is a component where you have changes specific to the antigen. So these dendritic cells and macrophages are sort of uh, they act as a bridge between the uh, innate immunity and the adaptive immunity by what is known as antigen presentation. So antigen presentation is an important component where it bridges the gap between innate immunity and adaptive immunity. So that is the importance. And then going further, you can look into the macrophages and dendritic cells. They are the ones that cause antigen presentation. They present a particular antigen to the target T cells or T cells. Next slide. Yeah. So you can see tumor. Definitely, a tumor is just like a normal cell, but it has some antigens which is little different from that of the normal cell. So what we call as tumor-specific antigens or neoantigens, and these becomes exquisitely important to target uh, and to use whatever is known as the targeted therapy or an immunotherapy. So these tumor-specific antigens are presented by the antigen presenting cells like the dendritic cells or the macrophages to the T cell, the activated T cell, which has the T cell receptor, and this causes adaptation or modification in the T cells to destroy the tumor cell. So this is extremely important that the new antigens in the tumor cells are important for the antigen presenting cell, and it presents to the activated T cell for cell destruction. Next slide. So yes, so what is basically this immuno editing? So whenever there is a cancer, we have three phases of cancer development. So the initial phase is elimination. So whenever there is cells constantly keep multiplying in our body, a cell takes its birth, it multiplies, and these cells die. So we have a cell cycle in place. So during this multiplication, birth, multiplication, and death, there is always a tendency for these cells to make mistakes and to have mutations. So these cells are mutagenic cells, and they have the potentiality to become cancer or oncogenesis. So there is a constant immune surveillance to take care of these mutations, and if the cells are defective, either they are repaired or they are killed by apoptosis. So whenever there is oncogenesis, when there is development of cancer in a human being in the initial part, the immune system is in place and it takes care of uh, the cancer cells, and this is what is known as immune elimination, where the immunity is the winner and it kills the cancer cells. Here there is no oncogenesis, or the rate at which cancer cell multiplies is far inferior to the immune surveillance or the immune attack. So in the initial phase, yes, the immunity does fight against oncogenesis and it takes care of cancer. And then comes a phase where the cancer starts fighting back, and even the immunity also tries to kill, and they attain what is known as immune equilibrium. Like the cancer is there trying to multiply, and the immunity is there trying to kill. So there is a constant war between the two, and they come to an understanding and they are in equilibrium. So, and there is what is known as immuno editing. Immuno editing, so we know that HIV or AIDS is an infection that causes immune suppression by destroying T cells. And we have so many drugs post transplant where we cause T cell suppression or B cell suppression. So we cause immune suppression. So cancer is also a disease which knows how to suppress the immunity. So this is what is known as immune edition. Like it edits our immune system to its own favor. It creates an immune suppressive environment around it. So when the immune cells are trying to attack the cancer cells, these cancer cells will have mechanisms to cause energy or weakening of these immune cells. This is what is known as immune escape. In spite of immunity being there, the cancer cells overcome the immune mediated cancer cell lysis and they escape from this immune mechanism. So the initial part is immune elimination, and then there is equilibrium, followed by the winning of cancer cells where they escape from the immunity and they start multiplying. So this is the basis of oncogenesis. Whenever there is cancer, always there is an initial check, and then later on the cancer wins and the immunity is weakened. So this was the basis of thought of developing what is known as immunotherapy. So, so you can continue. Your next slide. So this is how a cancer evades immune system. So how does cancer weaken our immunity basically? So you can see the way it weakens our immunity is it secretes certain immunosuppressive factors, and secondly, it causes reduced presentation. So like the cancer cells usually have certain antigens on their surface which are different from the self antigens. So these are called as neoantigens or onco-related antigens. So the cancer cells stop expressing these neoantigens and they behave just like a normal cell. And then they start recruiting immunosuppressive cells. For example, in our body there are certain cells which like regulate the immunity. Like if there is a requirement, the immunity is active, and then the immunity cannot be active beyond a point. It has to be suppressed. They are known as T regulatory cells. So these cancer starts recruiting these T regulatory cells, and thereby weakens the immunity. And the other way is it secretes cytokines to cause immune suppression around it. And thirdly, it starts expressing ligands on it, like a programmed death ligand 1, or it will start expressing a CTLA4 ligand. So by expressing these ligands on its surface, it starts immune suppressing. Next slide. Yeah. So what are the so this is a very important. So this is very important to know how we have evolved over a period of time as far as immunity and cancer is concerned. So in 1890s, what happened was there was a report on tumor regression following inoculation with bacterial infection. So we have some experiences in our career where a patient had a kidney cancer with multiple lung mets, liver mets, and this patient developed chickenpox. So after chickenpox, after the patient recovered, all these cancer lesions just disappeared. So this is quite this is anecdotal, and they have been seen in practice. So this is because these chickenpox viruses or varicella viruses cause some immune alteration in the body, which activates the T cells, and they are also anti neoplastic, and this causes regression of cancer. So then they understood that RCC has got a lot to do with immune mediated mechanisms, and then they proposed in 1909 that immunity has a significant influence on cancer, and then there was a system of immune surveillance was the reason for strengthening immunity, and that was the one that prevented cancer. And then we discovered that immune suppressed HIV patients were at increased risk of cancer. And then there were reports of tumor regression in patients administered activated lymphocytes with interleukin 2. And then in 90s, we started finding tumors were found to express antigens that can elicit a T cell mediated immune response. And then in 1995, the regulators of T cell activity were elucidated, spurring research into the role of immune checkpoints in cancer. And then the interleukin 2 got approved for cancer treatment. Next slide. Yeah. So this is how the thought process and the research is how they went on to find out how immune-mediated mechanisms are important in oncogenesis. Next slide. Yeah. So then after 2010, we had the first checkpoint inhibitor approved for cancer, and that is pembrolizumab. That is the wonder molecule of the day. Okay, next slide. So this is the cytokine-mediated immune suppression, and then we have therapeutic vaccines, and then we have adoptive T cell transfer, and then we have immune checkpoint inhibition and co-stimulatory molecule agonism. Next slide. So this is important that if you look into a T cell, it has receptors for both co-stimulatory and co-inhibitory receptors. You can see that CD28, OX40, and all these are required so that when there is interaction with these receptors, the T cells get activated and they start attacking the target cells. Whereas you can see the top two co-inhibitory receptors, the cytotoxic T lymphocyte A4 receptor and the PD1 receptor. These are extremely important because the cancer cells will express the CTLA4 antigen and the programmed death ligand 1, and they cause T cell anergy and cause immune suppression. So if you activate the left half of receptors, it causes T cell strengthening or T cell activity. Whereas if you activate the right half of receptors, then the T cell becomes inactive and goes into anergy. Next slide. So this is the CTLA4 pathway and the PD1 pathway. Their blocking has found to be extremely beneficial. So you can see the CTLA4 pathway, how dendritic cell interacts with the CTLA4 and causes T cell anergy. Similarly, you can see the tumor cell, how it interacts with the T cell by having PD1, PDL1 interaction. The PDL1 is the antigen present in the tumor cell and the PD1 is a receptor on the T cell. And the programmed death ligand 1 interacts with the programmed death 1 receptor on its cell. This causes T cell anergy and T cell death. So this is extremely an important pathway, and if you can inhibit this interaction of PDL1 and PD1, then we can re-edit the edited immunity and we can cause T cell activation to cause tumor lysis. Next slide. Yeah. So the physiological roles of checkpoint inhibitors, you can see the other interactions like the TIM3 and the LAC3 immune checkpoints, and these inhibitors are on the way and yet to come for clinical practice. Next slide. This is the OX40 mediated co-stimulation. These are important interactions to cause stimulation of T cells. The GITR mediated and the OX40 mediated co-stimulation are important for activating T cells. Next slide. So, to come to a conclusion on these immune the immune checkpoints or the immune receptors. So, cancer is a disease that arises in a milieu of immune suppression. So, all human beings or all cells always have a tendency for mutations and making mistakes, and there has been always a existence of an oncogenic potential in a human being. So this oncogenic potential is kept in check by our immune system, by a system what is known as immune surveillance. So there have been T cells which find out the class 1 MHC, and they find out the new antigens in these cancer cells, and whenever there is an oncogenesis happening in the body, an immune system called immune surveillance is in place and it prevents development of cancer. So, but when the cancer cells start the technique or the mechanism of overcoming our immunity and suppressing our immunity, then they undergo what is known as immune escape. So the three steps of immune elimination initially, followed by equilibrium, followed by immune escape happens. So whether cancer causes immunosuppression or whether immunosuppression causes cancer, both are equally important. So in an immunosuppressive environment, uh, there is a higher incidence of cancer, whereas cancer has an efficiency of causing a localized immune suppression and causes T cell energy by interacting with the co-inhibitory molecules like PD-L1, CTLA4, TIM1, what you saw in the slides. So when there is expression of these PD-L1 or CTLA4 ligand on the surface of these tumor cells, then these immune cells go into what is known as weakening or energy. So this is cancer-mediated immune suppression. So if you can inhibit the interaction of a PD-L1 and a PD-1, then you can cause immune activation, and this is what we call as immunotherapy. And we have seen this in clinical practice, that inhibiting these interaction of PD-1 and PD-L1 is extremely productive. And it is so productive that it has actually added a new dimension to cancer treatment and has improved survival in significant number of patients. So the future of oncology is immunotherapy, and we have to pick up a proper biomarker for immunotherapy. So we have always been exploring a proper biomarker. So one important biomarker is the PD-L1, which we test. So if a cancer is PD-L1 positive, so then we thought that probably that is the way to go. But it did not have 100% correlation with the immunotherapy activity, because not all PD-L1 positive cells responded to immunotherapy, or not all PD-L1 negative did not respond to immunotherapy. So then we came up with other markers like the combined positive score or the total positive score, where we not only count the presence of PD-L1 on the cancer cell, we also look into the tumor infiltrating lymphocytes around them. So this is what we call as the combined positive score. So with these CPS or TPS scores, we are able to further architect and understand which are the patients who are going to benefit from immunotherapy. So with this, I would have my final remarks that the cancer care is going to be immunotherapy based in future, because majority of chemotherapies have got a plateauing effect, or they will not act over a period of time, including targeted therapies. So there has always been an effort to find out how to overcome this cancer-induced immunosuppression. So we have had multiple examples in life, starting from a BCG used for bladder cancer intravesical, interleukin therapy, interferon therapy for renal cell carcinoma or hematological malignancies or melanoma. So now we have the PD-1 or the PD-L1 blockers. We also have the CTLA4 blockers on the way and available for cancer care. So the future for systemic anti-cancer therapy is always the stress is always on immunotherapy. This is different from conventional chemotherapy in that these act long and they have durable responses with minimal side effects. So with these remarks, I would thank everyone for their patient listening, and I would thank MSD for providing me an opportunity to speak and put my thoughts. So I thank you everyone, and Dr. Farooq, back to you. Thanks so much. Yeah.